Federal Ministry of Health, Malaria Case Management, Training for Health Professionals, November 2024, Adama. Management of uncomplicated malaria. Definition of uncomplicated malaria. Definition. 1. Symptomatic malaria or fever and the other associated symptoms. 2. The presence of a sexual form of malaria parasite in blood sample. No sign of severity or evidence of vital organ dysfunction. Clinical features of uncomplicated malaria are very non-specific and are shared by a number of different illnesses. Diagnosis at all times should be confirmed either by microscopy or rapid diagnostic test or RDT. Diagnosis of uncomplicated malaria. Clinical suspect. In malaria's area, a patient with fever or history of fever within the past 48 hours is assumed to have clinical malaria in non-malarious areas. In non-malarious areas, a patient with fever or history of fever within the past 48 hours and history of travels to malarious area within the last 1 month and the other common cause of acute febrile illness should be also looked for. Treatment based on clinical diagnosis alone is unreliable and when possible should be confirmed by laboratory test. Diagnosis of uncomplicated malaria. Parasitological diagnosis. The two main methods of parasitological confirmation are light microscopy and malaria RDTs. Required for confirmation of diagnosis of malaria. Recommended for all suspected cases in all transmission settings. Patients who test negative by malaria RDT or microscopy do not need anti-malarial medication. Advantage of parasitological diagnosis. It improves care of parasite-positive patients. Identification of parasite-negative patients for whom another diagnosis must be sought. It prevents the unnecessary use of anti-malarial drugs. It used to confirm treatment failure. It improves malaria case detection and reporting. Objective of treatment of uncomplicated malaria. There are 3 main objectives. 1. Clinical objective. 2. Public health objective. 3. Anti-malarial drug resistance objective. The first, clinical objectives. Eradication from the body of the infection that caused the illness or cure, to prevent progression to severe disease and prevent additional morbidity associated with treatment failure. The second objective is public health objectives. To reduce transmission of the infection to others, that means to reduce the infection reservoirs. The third one is anti-malarial drug resistance objectives. It prevents the emergence and the spread of resistance to anti-malarial. Tolerability, the adverse effect profile and the speed of therapeutic responses are also important considerations. Uncomplicated malaria treatment. Microscopy result. If positive for Plasmodium falciparum, the treatment is AL or altimetrin lumefantrine plus single dose primaquine. If positive for Plasmodium vivax, the treatment is chloroquine plus primaquine for 14 days. Microscopy result if mixed infection. Give Quartam or AL plus primaquine for 14 days. If microscopic result is no blood film for high-risk patients, the treatment is give AL or Quartam plus single dose primaquine. Alternative treatment for uncomplicated situation. Chloroquine not available for Plasmodium vivax. Recommendations: use Quartam or AL. If Quartam or AL not available by Plasmodium falciparum or mixed infection, recommendation: use DP. Chloroquine and Quartam or AL not available for Plasmodium vivax, use DP. Uncomplicated malaria treatment in pregnancy. No need to admit or label all malaria in pregnancy as severe malaria. Treat non-complicated cases on non-pregnant adults. Give full course Quartam or AL in all trimesters for Plasmodium falciparum or mixed infection. Give full course chloroquine for Plasmodium vivax infection in all trimesters. Single dose primaquine and radical cure is contraindicated in all trimesters. DP is indicated as a second line or alternative drugs. Uncomplicated malaria treatment in pregnancy continues. Weekly chloroquine prophylaxis for Plasmodium vivax infection. After completing 3 days course of chloroquine, pregnant mother will take 2 taps of chloroquine weekly until delivery and 6 months of lactation. Then radical cure is indicated. IPTP with fancider is not recommended in Ethiopia. Uncomplicated malaria treatment in HIV, TB, and malnutrition. These patients are at high risk for treatment failure and progression to severe malaria. Factors that reduce the anti-malaria drug bioavailability are drug interactions, weak immune system, reduced drug absorption, hypoalbuminemia. However, there is insufficient evidence to change the drug and the dosing. They should be monitored closely. Supportive treatment in a complicated malaria. A. Arrest fever. Treat especially in children. Use paracetamol 15 mg per kg every 4 hours. Fanning and tapping sponging. Use the IMNC algorithm. B. Prevent hypoglycemia. Encourage to take food and fluids. Anti-malaria drug information. 1. Artemether lumefantrine or AL. FDC drug given 2 times a day for 3 days has very fast parasite elimination, so reduce fever promptly. Effective against mature gametocyte clearance. Effective in multi-drug resistance areas. Has no any evidence of organs or system-specific toxicity. FDC means first line. Anti-malaria drug information continues. Indication of AL or Quartam. Uncomplicated Plasmodium falciparum malaria. Uncomplicated mixed Plasmodium falciparum and Plasmodium vivax malaria. Uncomplicated PV or Plasmodium vivax when chloroquine not available. If no RDT or blood film test for high risk and other cause of fever rule out. Anti-malaria drug information continues. Contraindication of Quartam. Person with a previous history of reaction after using the drug for chemoprophylaxis combined with other drugs or alone. Person with severe and complicated malaria should not be treated with oral medication. Anti-malaria drug information contains tablet containing 20 milligram artemether plus 120 milligram lumenfantrine or AL in a fixed dose. Weight per kg. Age. Weight per kg less than 5 kilogram. Age less than 4 months. Day 1 immediate 1 tablet. After 8 hours 1 tablet. Day 2 morning 1 tablet. Evening 1 tablet. Day 3 morning 1 tablet. Evening 1 tablet. Color code yellow. Weight per kilogram 5 up to 14 kilogram. Age 4 months up to 2 years. Day 1 immediate 1 tablet. After 8 hours 1 tablet. Day 2 morning 1 tablet, evening 1 tablet. Day 3 morning 1 tablet, evening 1 tablet. Color code is yellow. Weight 15 up to 24 kg. 3 years to 7 years. Immediate 2 tablets. After 8 hours 3 tablets. Day 2 morning 2 tablets, evening 2 tablets. Day 3 morning 2 tablets, evening 2 tablets. Color code blue. Kilogram weight 25 up to 34 kg. 8 years to 10 years. Immediate 3 tablets. Day 1 morning 3 tablets. Day evening 3 tablets. Day 2 morning 3 tablets. Evening 3 tablets. Day 3 morning. Day 3 morning 3 tablets. Evening 3 tablets. Color code brown. Greater than 35 kilogram. Age equals to or greater than 10 years. Immediate 4 tablets. Day 1 immediate 4 tablets. After 8 hours 4 tablets. Day 1 4 tablets morning. Evening 4 tablets. Day 2 greater than 35 kg. Age equals to or greater than 10 years. Immediate 4 tablets. Day 1 immediate 4 tablets. After 8 hours 4 tablets. Day 2 morning 4 tablets, evening 4 tablets. Day 3 morning 4 tablets, evening 4 tablets. Color code green. Anti-malaria drug information continues. 2. Chloroquine CQ indicated for all patients with PV. PO. Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria infection. It is rapidly absorbed from gastrointestinal tract, has low safety margin, and is very dangerous in overdosage. Effective against the blood stage parasite. The dosage is 10 mg base per kg on day 1 and 2 then 5 mg base per kg on day 3. And Primaquine, the third one. It is effective against all stages of gametocytes. The only drugs which can act in the hepatic stage of parasites, including the hypnozoites, the active metabolites, if it is byproduct, are very toxic, which can reduce hemolysis, has low safety margins, indicated for radical cure against Plasmodium vivax, prevention of transmission against Plasmodium falciparum. Pre-marketing contraindication. Pregnancy woman breastfeeding infant less than 6 months of age. Infant is less than 6 months of age. Moderate to severe G6PD enzyme deficiency. Any condition that predisposed to granulocytopenia such as acute rheumatoid arthritis and SLE. Pre-marketing treatment schedule. Weight per kg. 8 up to 19 kg. Age years 6 months to less than 5 years. Number of tablets. 7.5 milligram tablets, half. 15 milligram tablets, no. 19 to 24. Weight per kg. 5 up to 7 years. 7.5 milligram tablets, 1. 15 milligram tablets, half. 25 up to 35 kilogram, 80 to 10 years. 7.5 milligram tablet, 1. 15 milligram tablet, half. 36 up to 50 kg, 11 up to 13 years. 7.5 milligram tablet, 1 and a half. 15 milligram tablet, 1. 50 plus kg, about 14 years. 7.5 milligram tablet, 2. 50 milligram tablet, 1. Anti-malaria drug information. Hydroarteminism. Piperaquine DP, a fixed direct combination used to treat Plasmodium falciparum and Plasmodium vivax malaria, used in all age group and pregnant mothers. Side effects are uncommon and no organ-specific toxicity documented, indicated during treatment failure or as an alternative treatment when the first line is not available. Treatment failure. It is failure of anti-malaria drug to resolve parasitemia and presence of fever after the third day of treatment. Common cause: poor adherence, underdosing, vomiting, drug interaction, misdiagnosis, substandard medicine, drug resistance. Steps in the management of treatment failure. Determine the duration. That means before or after 28 days. Check the issue cause of treatment failure. That means evaluate the patient as a nucleus. Confirm treatment failure with repeat blood film and do other tests. That means RDT is not recommended. Check for severity, symptoms, and signs. Decide the treatment plan. Management of treatment failure. Within 4 up to 28 days, for patients who have reported poor adherence, repeat the first line regimen based on parasite species. For patients who have reported good adherence, change to the second line drug DP for all Plasmodium species. Note: be careful. Patients should complete the already started radical cure. After 28 days, treat all patients with the first line regimen based on parasite species. Referral. All patients with clinical or laboratory evidence of severity should be referred from health center to hospital. Provide first dose of pre-referral treatment before referral. Remember, a delay in referral could cause the unnecessary death of the patient. Management of severe malaria.